Uh, just wait.
Good afternoon, everyone, and welcome to MedGurukul conducted by Agilus Diagnostics. The topic today is on lab investigations of autoimmune encephalitis. Autoimmune encephalitis is a topic that we do not know much about. How to investigate it, we know even less. And things have changed rapidly over the past decade or so. We now have tests for the diagnosis of autoimmune encephalitis and also increased awareness about this entity. It is now estimated that a large percentage of cases of encephalitis turn out to be due to autoimmune encephalitis. To take us through this topic, we have Dr. Deepak Sanghavi. Dr. Deepak is Vice President Operations, West and South for the Agilus labs, including the Fortis Hospital labs in West and South. He is also Chief of the Mumbai Reference Lab. So, Deepak, I would request you to please start your presentation. We can't hear you. You're on mute.
Yeah.
Yes.
Thanks, Dr. Abha, for the kind introduction. Good afternoon, team. So today we will be discussing the topic of autoimmune encephalitis. So on the you can see my team and the department that we have in our Mumbai Reference Lab in the photos that I have pasted on the first slide itself. Yeah. So as encephalitis, it means inflammatory condition of the brain by the definition. So we know that there are two main causes of encephalitis. One is the infectious causes and the non-infectious, which we also call as immune-mediated. And that is the topic of today's discussion, the autoimmune encephalitis. So when we talk about this condition, we are also talking about acute encephalitis, which leads to a neurological disorder. It is very rapidly progressing. The clinical manifestations may be also diverse and therapeutic outcomes also are diverse. And hence, the clinicians want an urgent diagnosis for such cases so that they can treat the patients accordingly. The incidence of autoimmune encephalitis or acute encephalitis is approximately 5 to 10 cases in 1 lakh population per year. So it is very rare, but it is very, very important to diagnose these patients so that the such patients will get treated on time. We also have to know that all age groups are affected by acute encephalitis. So coming to our topic of autoimmune encephalitis. So here we are talking about subacute deficits of memory, cognition, and sometimes the patients may have suppressed level of consciousness and coma. So these are the clinical conditions landing up to the neurologist and they needing attention for this condition. From the pathology perspective, we have to know that these autoimmune encephalitis disorders are normally categorized into three main headings. One is the pathogenic antibodies to cell surface antigens, which we are going to discuss further. There are antibodies to intracellular synaptic proteins. This is also we will discuss in detail. And the third important condition is a paraneoplastic condition, which also we will discuss in detail in our presentation. So a little bit about the history, how this terminology and things came into picture. So in 1960, it was found that many of the patients who were going to have cancer or who had cancer had some limbic encephalitis like picture in this them. And when laboratory diagnosis was tried, it was found that many of them had antibodies against neuronal proteins. And then one by one, they the scientists started finding out such antibodies. Like you find that in 1985, they found U antibody, then U antibody, then amplifying antibody. So such names started coming into picture with the list of antibodies where the patients had some cancer and there was autoantibodies against neuronal proteins. Then came MA, then recently in 2005, NMDA receptors, AMPA receptors, and now new receptors have come after 2010, that is Caspia2 and GABA receptors. All these were found to be in the list of conditions of autoimmune encephalitis. The incidence of such autoantibodies in such patients of encephalitis was found to be 8%. So it was quite high. And that is why now we are having more cases prescribed by clinicians to find these conditions. So when we talk about autoimmune encephalitis, the pathophysiology part of it is we have to know that the neuronal junction is the two neurons. They when they come at junction, then there is either excitatory receptors or inhibitory receptors, and this is also called as synaptic plasticity. This is very important for the neurons to work, especially for the memory and cognition and learning perspectives, and hence this condition is called synaptic. Hello,
Dr. Deepak, there's an
Yeah.
echo coming. Can you move closer to the mic, please?
Okay, yeah. Can you hear me now?
This is better.
Yeah. So this condition where the junction at the junction there are excitatory and inhibitory receptors is called synaptic plasticity. And excitatory receptors like NMDA or AMP receptors, and for the inhibitory we have GABA, that is gamma aminobutyric acid receptors. Autoantibodies found against these antigens affects the neurotransmission and hence impacts the synaptic plasticity. So this terminology we have to know that it impacts the synaptic plasticity and neurotransmission is getting affected because of such autoantibodies against excitatory and inhibitory receptors. So this is the pathophysiology part of autoimmune encephalitis. So coming down to what are those autoantibodies? So they can be intracellular or extracellular, or maybe on the cell membrane structures. So when we talk about intracellular antigens, then they are mainly the neuronal nuclear or neuronal cytoplasmic. So when we talk about neuronal nuclear, they are also called as U antibodies, that is ANA1, or maybe Re antibodies. They are called ANA2, and then there is ANA3, and maybe MA2 MA2, MA1, and ZIG4. These are the autoantibodies which are neuronal nuclear. While there are U antibodies, that is PCA1. There is a PCA2 antibodies, there is TR antibodies, there is a tritine antibodies. They are all neuronal cytoplasmic antibodies. Then there are antibodies against presynaptic structures. The list includes GAD65 antibodies and ampifysin antibodies. And there are antibodies against glial proteins, that is the CRMP5, CB2 antibodies, or SOX1 antibodies, or MOG antibodies, that is against the oligodendrocytes. So these are the list of intracellular antigens. So we have to know these names because this is what is prescribed by the clinicians, and we as a laboratory we have to report these autoantibodies. Then there are antigens located at the cell membrane and antibodies will be against them. For example, the ionotropic channels and receptors, that is the acetylcholine receptor antibody, which is very commonly found also positive or commonly prescribed also, that is ACRAB antibodies, NMDA receptor antibodies, AMPA receptor antibodies, which includes GLU-R1 and GLU-R2, and DPPX antibodies. So there are voltage-gated calcium channel antibodies also, which is rarely asked. Then there are metabotrophic channel and other receptor antibodies, which mainly include the GABA antibodies, which are the inhibitory antibodies. So they are against the antigens at the cell surface. Other list also includes against the astrocytes, that is aquaporin antibodies, which we also call as NMO antibodies. Then there are MuSK antibodies, Caspr antibodies, and emoji antibodies, that is myelin oligodendrocyte glycoprotein antibodies. And further, the Guillain-Barré syndrome, commonly been diagnosed with help of ganglioside antibodies, includes the proteins like GM1 antibodies. And then there are extracellular antigens, which are synaptic proteins, also called as LGI1 antibodies. So I'm just putting this in little bit red font for all of you to know that these are the antibody names which, as a laboratory, we are reporting. So now, just to understand, when we report, we also have to know what are these clinical history that we have to discuss with the clinician, or which are the clinical conditions in which these antibodies will be found. So as a classical case of a patient with a neurological disorder, when the clinician is suspecting autoimmune encephalitis, the patients may have neuropsychiatric features or may have only neurological features. So when they're having neuropsychiatric features like psychosis or personality change, agitation, behavioral changes. So if a child is young, then the most common conditions which are found are mainly the NMDA receptor antibodies, and second is the GABA receptor antibodies. So such NMDA receptor patients will have autonomic dysfunctions, stereotype movements for the patients. While the GABA patients will have more of epilepsy, hallucinations, and coma. If the patient is old age, then the most commonly antibodies, if the patient is having neuropsychiatric features, the found is anti-AMPA antibodies. The patient may be having epilepsy and ataxia. When the patient is not having neuropsychiatric and only having neurological features, the clinician will suspect if there is a facial brachial dystonia, or maybe neuromyotonia. So basically muscle and face both involved, or there's dystonia in the muscles. Then if the face and face is involved, it's mainly the VGKC LGI1 antibodies. If the neuro and muscles both are involved with the memory loss also, then VGKC second part is the Caspr antibodies, which are also called as Morvan syndrome. So these are the common conditions when there is a dystonia seen. If there is a cognitive decline and including the muscle jerks, then the clinician may suspect Hashimoto's encephalitis. Here we are talking about thyroid antibodies and brain involvement. And encephalomyelitis conditions with myoclonus, where the doctor will suspect glycinal antibodies, which are also called as anti-antibodies. So these are the clinical conditions where you will find these antibodies to be commonly positive. Again, listing the same thing in another table. What are the clinical clues for asking for the antibodies, and what are you going to ask as a history to correlate before releasing the report? So you will have psychosis, NMDA receptors, AMPA receptors. You have status epilepticus, mainly the GABA receptors. You have clinical condition called a stiff person syndrome. So here you will have GAD65 antibodies done from serum or CSF. So you have two sample types also, which we will discuss. That these antibodies can be asked from serum sample as well as CSF sample by the clinician. When the patient is having myoclonus or hyperexcitability, then DPPX antibody may be asked for the clinician. So all these are different types of antibodies and clinical conditions which we have to know before reporting these cases. And also we have to know that they are done from serum sample as well as CSF sample. And there is a list of antibodies which are more commonly found in serum and some antibodies mainly found in CSF. So accordingly, the clinicians will ask the respective test from the respective sample. So again, coming down to that, what all clinicians will do, because they are, apart from this antibodies, you may also have other prescriptions from the clinicians, like they will do an MRI also in this, because they have to rule out other conditions like meningitis, and they will go for infectious disorders to be ruled out, like herpes, or maybe they will also do an EEG also, they may do CMB also. So all other tests also they will try to rule out. The infectious etiology also they will try to rule out. And finally, if they find autoantibodies, which is mainly a blood workup and also a CSF workup, they will go for immunosuppression for these patients to treat. Or maybe if there's an underlying tumor found, they will treat the tumor. So other differential diagnosis which you have to know, because you know multiple sclerosis is diagnosed by oligoclonal band. So sometimes you will find the test asked along with oligoclonal band, because the differential diagnosis is multiple sclerosis. Maybe vasculitis. So one more test which will be commonly asked along with that will be ANCA testing. And then there are infectious PCR or infectious antibodies will be asked for herpes, varicella zoster, enterovirus, and West Nile. Sometimes vitamin deficiency also mimics this autoimmune encephalitis conditions. So you should have vitamin B1, B2, B complex vitamins will be ruled out by the clinician. So these are the list of PCRs. You know that we are doing all of these infectious PCRs. So you can discuss with your neurologist. The herpes PCR, CMV PCR, varicella zoster, enterovirus, all of them are done in our lab from the CSF sample also and from the blood sample, but mainly the CSF, because it's a acute encephalitis condition. There are cryptococcus is a differential diagnosis, tuberculosis is the differential diagnosis, toxoplasma. So these all other tests may be also found along with this test. Now coming down to again, how do we diagnose these antibodies? We have seen the overall theory about what is autoimmune encephalitis. There are autoantibodies against intracellular proteins. There are autoantibodies against the extracellular. There are autoantibodies against the cell surface. These all are linked to the neuronal junctions, the synaptic plasticity. So how do you diagnose these autoantibodies? So there are three main methods. One is the indirect immunofluorescence. In indirect immunofluorescence, you have kits available which are tissue-based. Tissue-based means there will be basically actual brain tissue being cut like slices and pasted on the biochip slides, where you can do the immunofluorescence processing, and then based on the fluorescence, you can diagnose the antibodies depending upon the area of the brain involved. Maybe cerebrum, maybe cerebellum, whichever area is involved, you will be able to diagnose those antibodies. And then now the new assays which have come, which are more specific and better, are the cell-based assays. So I will take this more into detail about the cell-based assays, because they are very accurate, more sensitive, and the diagnosis is also very fast. So in indirect immunofluorescence, there are two types of kits available. One is the tissue-based assay. Second is the cell-based assay. We are mainly using cell-based assays. And the second commonly used method is the immunoblot method, where many antibodies or many antigens will be coated on the blot, and you'll be able to diagnose many antibodies from the immunoblot. So as you can see the picture also, this is the automated instrument for blot on the lower side. And this is the auto blot. It's also called as a Euroblot instrument. And here we have an immunofluorescence microscope. And this is the immunofluorescence slide on which you are actually seeing the fluorescence. Now talking about cell-based assays. So what is actually done is this antigen of the under discussion is actually synthesized into a DNA, and this DNA is inserted into a plasmid, and this plasmid then in combination with DNA is infected into hex cells. So basically these hex cells are the cultured brain cells where these antigens are incorporated, and then hence they are called as transfected cells. So these transfected cells, when you do the processing with the immunofluorescence antibody, the positive cases will show you fluorescence on the transfected cells. If it is positive, the case is positive. If it is negative, the case is negative. So you will see the slides like this. So as you can see on the right side, you have transfected hex cells. So all these are different types of hex cells. Some may be round, some may be, you see the projections, and depending on the positivity, it's very easy to diagnose. Fluorescence is positive, non-fluorescence negative, but you have to have some areas also for more specific reporting. So here is the biochips of NMDA, biochip of Caspia2, AMPA, LGI1, and GABA. And if you use a tissue-based assay, then you are actually having a cerebellum or a cerebrum tissue where you are actually seeing the cytoplasm, or maybe the granular positivity, maybe the nuclear positivity. All those kind of reporting will be done in if you are using a tissue-based assay. So cell-based assay is more specific. As you can see, there is no confusion. If you're seeing the so many cells, you can see in each of these biochip, there are more than 50% cells which are positive. So when the case is more than 50% cells are positive, the case is positive. You may have weak positive reporting. If you have only 10% cells being positive and 90% cells are negative, then we report like a weak positive. Or maybe the patient needs a follow-up because the autoantibody levels will grow. Or maybe if the patient is on treatment with immunosuppression or steroids, then the number of cell positive will reduce. So you may have a first case which is 80% cells are positive, and later on you may have only 10% cells are positive. So the autoantibody levels are getting reduced. Second commonly used method for detecting these antibodies are the immunoblot. So you have this blot, you have this strip which has multiple antigens coated on it, and when you subject this to the serum or CSF sample, you get this bands positive. So here, as you can see, the list is there: ampifycin, CV2, Yo, Hu, recovering, SOX1, Titin, ZIC4, GAT65. So these all are the names of the tests that we are getting, and how do we report based on the band that we see. And we also use the automated instrument for scanning this band and give you a number. So this number is also kind of a quantitative number which is needed by clinicians, and we can report that number also to the clinicians. So these are the list of, again, antibodies. So this is one of the table, as you can see here, again, reverting the point that the same antibodies, you should also know this kind of a table. What will be the symptoms? What are the manifestations? What are the associated tumors? What is the demographics? So that you can discuss with the neurologist and find out that your report is correlating. Maybe they want to discuss the case with you, and you can, they may tell you to see more, or you may even prescribe the doctor saying that the case looks like more of as per the history, not an NMDA case, but an LGI1 case. So you should go for LGI1 test. So this is a little bit table about differentiation between VGKC and NMDA antibodies. I will not go into detail because a little bit more of theory behind it. But you have to know the doctor will have an MRI report, will have a CSF routine done, and some other clinical findings which may help you for clinical correlation. So now a little bit about each of the antibodies. As you can see here, every antibody has their own list of what we should have. Like it will be mainly found in women population. The NMDA antibodies will be more of children and in young age group, and mainly on the females. And the risk of relapse also is there. So every antibody has their own prognosis that we have to know, and this is what we here are there to discuss with the clinicians, and we will put it in our IR also. We have put many things in our IR of the report format also. So these are the clinical conditions we have to know in which of the antibodies the seizures will be more common. That is epilepsy will be more common, or which are the conditions where psychiatric symptoms will be more there. So this is mainly about the history part of it and what antibodies will correlate. So this is about LGI1, where you will mainly find hyponatremia, and the tumors associated will be thymoma or the lung tumors. Casper antibody also will be mainly seen in the Morvan syndrome, again repeating the same thing. GABA antibodies seen mainly in the epilepsy or the neuroendocrine tumor of lung or small cell lung carcinoma. This is AMPA antibodies. The tumors will be associated will be ovarian tumors, thymoma, lung, breast tumors. DPPX antibodies mainly seen in the myelinic plexus antibodies, and diarrhea and weight loss will be the main feature in DPPX. So autoimmune encephalitis, any patient of autoimmune encephalitis with diarrhea, the doctor is suspecting autoimmune encephalitis with diarrhea, then they will go for DPPX. So there are two kinds of tests. One is autoimmune encephalitis with 6 markers, and there is one autoimmune encephalitis with DPPX, that is 7 markers. So in that, with DPPX, the symptom that we use for correlation is a diarrhea, apart from autoimmune encephalitis. So coming down to the third condition which I was talking about is the paraneoplastic syndromes. So basically, as the name suggests, paraneoplastic means the autoantibodies or neurological syndromes are associated with some tumor, but they are not directly triggered by the tumor, neither by metastasis, neither by any vascular or metabolic conditions. So they are basically, the tumor cells have neuro-oncoproteins, and autoantibodies are against those neuro-oncoproteins. So it is just an basically clinical association. So you are able to actually detect a tumor, or maybe detect a tumor well in advance, because these autoantibodies normally come 5 to 6 years before the tumor, and maybe with the tumor also they are associated. So they are called as paraneoplastic antibodies. So you're talking about a neurological syndrome associated with a tumor and diagnosed by using autoimmune antibodies against the neuro-oncoproteins. So why ANA like or immunofluorescence is not used mainly for paraneoplastic syndromes? Because there can be an ANA interference in such cases, and hence immunoblot is the commonest method used for diagnosing paraneoplastic syndromes, which I have shown you the immunoblot. So what are the well-characterized onconeuronal proteins? So again, coming down to the same list, U, YO, RE, ampifycin, CRMP5, MA1, MA2, recovering. So these are the commonly associated onconeuronal antibodies, and the tumor conditions which are having these antibodies. So small cell lung carcinoma will have mainly U antibodies. Ovarian or breast cancer will have mainly U antibodies. So as you can see here, a female patient with neuronal condition, you have to think about if you get a U positive antibody, then doctor will go for searching an ovarian and breast cancer or metastasis. Similarly, if ampifycin is seen, then again breast tumor or small cell lung carcinoma, and recovering antibodies in lung carcinoma, and even MA2 or we also call as PNMA2, basically PNMA2 antibodies, mainly the testicular tumors. So here you will, when you get an antibody, the doctor will start suspecting those tumors and try to check those tumor conditions. There are partially characterized onconeuronal proteins like ZIC4, SOX1, ANA3, that is ANA3. The most common clinical condition, small cell lung carcinoma. So as you can see, a small cell lung carcinoma leads to a lot of onconeuronal protein autoantibodies, and they are detected by paraneoplastic antibodies. So this paraneoplastic syndrome, also called as anti-neuronal antibody. So our test name can be an anti-neuronal antibody or a paraneoplastic syndrome, and it can be like a 6 antigen, which are more common listed in the previous this one, or maybe a 9 antigen, or maybe 12 antigen. So we have 3 kinds of kits to diagnose the paraneoplastic syndromes. So most commonly, as I can see in this chart also, that U antibodies are more common, U antibodies are more common, Caspr2 antibodies are more common, but NMDA is less common, GABA is less common, ampifycin is less common. So we also know the more positivity rate on the autoantibodies from this chart. So that is what we used to, we also get in our in-house data. And as you can see, 31% of results are different from initial antibody request. What does it mean? The clinician may be suspecting something different, and the antibodies in 31% of such cases comes different. Hence, the whole panel should be asked by the clinician. If they are really suspecting the clinical condition, they may ask for a specific antibody or otherwise a complete blot, so that you do not miss of any other antibody. So concluding with the whole presentation, that autoimmune encephalitis is a very important disorder. 8% of the cases will have autoantibodies. The proper diagnosis and management require detailed history, physical examination by the clinician. The neurologist will do an MRI, EEG, lumbar puncture, that is CSF, routine microscopy. You can ask those findings and for correlation. And there is a broad group of autoantibody tests to diagnose them and even exclude the autoimmune conditions. So you will have to do infectious PCR test also to rule out these things. And whenever such autoantibody is detected, the risk of neoplasm is very high. The doctors will find maybe in your future, or maybe currently the patient may be having any tumor and he will suspect that. And the treatment will mainly about the immunosuppression of this autoantibody and the treatment of the tumor, so that the patient becomes better. Thanks a lot from my side for this presentation.
Thank you, Dr. Deepak. Your presentation highlighted autoimmune encephalitis, its various modes of presentation, the antigens and the antibodies that are associated with it, and how to select the right test. So with that, and I would also like to highlight how in recent times we have seen an improvement in the technology that is available in the IFA section in our Mumbai reference lab. And we are also seeing a wider test menu that is available now. So
Yes.
Dr. Deepak has been instrumental in this progress that we have seen over the past. He has been now with Agilus for 2 years plus.
Right.
2 years plus, and we have seen a lot of improvement in the IFA menu that is available. If there are any questions, you can put them on the chat, please. Any questions, any queries?